Hello and welcome to the Australia-India Institute panel discussion on managing the COVID-19 pandemic, the role of data. My name is Jane Heyworth. I'm an Honorary Research Fellow in the School of Population and Global Health at the University of Western Australia. And it really is my honour to be able to facilitate this panel discussion tonight. And we have three excellent speakers. And before I introduce each of the speakers, I'll just tell you a bit about the format of this evening and give a very brief background to this session. So in terms of format, we have the three speakers who will each speak for 15 minutes each, and then we'll have a discussion at the end for another 15 minutes. If you have any questions, could you please type them into the chat box? And if you would like that question to go to a particular speaker, you can also indicate that. So we will remind you to do that, but I will be looking at the chat box and reading out the questions from the chat box for the panel to address. So please do that. And so just before we start, obviously data has been vital in our response to the COVID-19 pandemic and also in evaluating our response. But much of the data has come from high resource settings from North America, Europe, etc. And we've had less information and data about India and low resource settings. And as it's India Week, it is important that we discuss this issue in relation to low resource settings. So that's just by way of a very brief background, and I want to get straight into our speakers because their information is going to be really interesting for us tonight. So our first speaker is Professor Laxminarayan. Professor Laxminarayan is the founder and director of the Centre for Disease Dynamics, Economics and Policy in Washington, DC. He's a senior research fellow at Princeton University and an affiliate professor at the University of Washington. He has been very instrumental in bringing the issue of drug resistance to the attention of leaders and policymakers worldwide. But this evening, Professor Laxminarayan is going to speak about the epidemiology and transmission dynamics of COVID-19 in India. So if you're able to share your screen and your slides, I'll hand directly over to you, Professor.
Thank you, Professor Heyworth. It's a pleasure to be here. So I'll show my slides. Can you see them?
I can, yes. Thank you. Okay, I'm sure everyone else can too.
Great. So I'll jump right to it. So I've been in India through much of the COVID pandemic, and it's obviously been an interesting time. India has had challenges on many fronts, but India has also had the advantage of having tons of data related to COVID, just because of a legacy of being able to do contact tracing and follow up at a scale that has been difficult in many other countries. So some of the data I'm about to show are possible because of the kind of work that the Indian public health system was able to get into. So the first paper I'll talk about, the study was published last year on the epidemiology and transmission dynamics of COVID in two of the southern states of Andhra Pradesh and Tamil Nadu. Together, they make up about 130 million population. So obviously considerably larger than Australia, but much bigger than most countries around the world. This was the largest study of COVID transmission to date. And it covers about 3 million people traced and reliable data on 575,000 contacts traced from 85,000 primary cases and covered about 5,700 deaths. Now, this was the first wave related analysis. We have another one which is coming out soon, which covers the second wave as well. But this is really the first wave paper, and I'll talk about this in a bit. So incidence obviously growing rapidly, starting from May, June into July. You can see that new cases were primarily concentrated around the urban centers. So COVID initially was very much an urban disease, and then moving into rural India. fairly similar patterns, even when you look down and drill down to the level of district in both Andhra Pradesh and Tamil Nadu. Andhra Pradesh had a slightly later growth in cases than Tamil Nadu did, but at the end of the day, they're pretty similar states in terms of testing capability as well as in terms of population and socioeconomics, and they sort of track each other quite nicely. Now we had very good data on contact tracing. There were two kinds of contacts defined: high-risk contacts, which were, you touch bodily fluids, or you have direct physical contact, or you were in a shared conveyance within 3 rows of the index case, and low-risk contacts were just sharing the same space or being in the same conveyance without being, very close to the other person. Now, trace contacts tended to be younger. They were more often female than their linked index cases, and test positive individuals were, like I said, 1.3 years younger and less likely to be male than the overall population. Now, this was the first major finding from the study, which is to look at secondary attack rates, and secondary attack rates, obviously very important for us to understand. 7.5%, if you look at any sort of contact, and community contacts were only about 2.6% secondary attack rates, which means that of every 100 people who are exposed to an index case in a community setting, the likelihood of getting the disease was only 2.6%. In households is about 9%. And the 9% secondary attack rate in households was remarkably similar to what had been observed in both South Korean studies. There was a South Korean study that was about a tenth the size of ours, but had a similar finding both for community secondary attack rates and for household secondary attack rates. There hasn't been another study which looked at travel together. Our sample size was small, but we did find a very high likelihood of transmission, particularly for high-risk travelers. And healthcare settings was also pretty low, much less than one would have expected. Again, small numbers there. Now, interestingly, the index and contact cases happen to be in similar age groups. There is a bit of a myth that, because Indian households are multi-generational, that contacts happen widely between people of different age groups. Now, studies before ours, which just look at just contact tracing matrices, have found that that's not necessarily true. Even in these multi-generational type homes and neighborhoods, young people tend to spend a lot of time with other young people, middle-aged people with other middle-aged people, and elderly people with other elderly people. And this is a nice graphic that was done by The Economist based on our study, which showed that people were more likely to infect their own age group, and young adults were big spreaders to all age groups, presumably because they go out, they're more likely to get infected, and then they come back and transmit to many other people. So the left side is the age of the infected person, and the right is the age of the people subsequently infected. And the very strong 45-degree line shows that that people tend to really infect people of their same age by and large. Super spreading was a feature of our study. Now, people think of super spreading really as this, a crowded marketplace, one person giving the disease to many other people. And there have been examples of super spreading in many countries where, there are these singular events. In India, it was a Tablighi Jamaat event where basically it was a religious gathering that continued past the lockdown and resulted in thousands of secondary infections. Similarly, in Coimbatore market, which is a vegetable market in South India, in Chennai, also resulted in a few thousand cases. But what we find in our study is that 70% of people who tested positive did not really infect anyone else, and the vast majority of subsequent infections were caused only by a few people. And this is really classic super spreading in the sense that each of these other people is not transmitting to many other people. This is from a study in Hong Kong. You do have these kind of events where one person will transmit to many people who then pass on the infection, and they are an index case for that. But the vast majority of what we call super spreading is heterogeneous spreading, which is that single people give it to 3, 4, 5 people, but the vast majority don't give it to anyone. Of course, we've seen examples of this in Austria, where an outbreak in the ski village was linked to cases in 45 different countries. And the original paper by Jamie Lloyd-Smith in Nature really shows what this K value is. And this, in our study, showed that the K value for for COVID, SARS-CoV-2 was quite similar to the original SARS-1. And it is very much of a super spreading kind of a disease, which means that targeted control policies can do much better than population level policies. But provided we're able to identify predictive correlates of higher infectiousness, and this is where we've really struggled because we haven't had the evidence to really be able to separate on the basis of this and to target policies. When it comes to mortality, as you can see, the adjusted hazard ratio for mortality increases significantly with age, very low in the 0 to 4 age group or the 5 to 17 age group, but gets to be quite high in the 85 plus age group. Men more likely to die than women. And we also find that over time, as the date of testing progressed, the hazard ratio dropped, which means that possibly because medical care was improving, the likelihood of someone dying was actually going to be lower just because the system was getting better organized. And this is also reflected here why Tamil Nadu has a higher hazard ratio than Andhra Pradesh. Tamil Nadu had much earlier cases and therefore earlier deaths than Andhra Pradesh, and Andhra Pradesh may have benefited from the delay in cases. If you look at case fatality ratios, which is what everyone is interested in, and you can see that the case fatality ratio in the 85 plus age group is 100 times what it is in the 18 to 19 age group. So huge differentials here, and certainly men are more likely to die than women. But if you cut across all age groups, it's about 2.06. But again, the overall number is meaningless unless you've really broken it down by age, simply because India is by and large a pretty young country. When you compare case fatality ratios by age group across different countries, India is pretty average across all countries. But if you look at the below 70 age group, Indians are more likely to die in each of these age groups, if they were infected. And this is possibly because of higher rates of comorbidities and especially undetected hypertension and diabetes, and also worse access to healthcare. Now we have a new study that's going to be out next week in Lancet Infectious Diseases, and what we had here was a very rich data set for Madurai, which was data from a city which has 3.2 million people. We had data on about 440,000 tests, all done prospectively, and almost 16,000 infections identified, and very standardized data collection on symptoms and chronic comorbid conditions as part of the routine intake. We also had a seroprevalence study that was done as part of this. So we had data on all testing, all cases, and all deaths. You could see why they were being tested. And the test indications, the vast majority were because of symptoms, but we also had some because of travel, contact, and so forth. And these were the test positivity rates also by indication. So obviously symptoms accounting for a large proportion of these. Now, this is an interesting finding, which is that comorbidities are important predictors of positive RT-PCR results. So people who are of older age groups and who are symptomatic are more likely to be RT-PCR positive. And if you look at symptoms predicting infection, you can look at fever alone, which is the blues, or the fever. All of these are with fever. So fever alone is about, the odds ratio is about 5. The adjusted odds ratio is about 5. But for whether it's pharyngitis or cough or myalgia, or at least for most of these, the condition along with the fever is far more likely to indicate infection than without the fever. And if you look at comorbidities predicting infection, you could see that diabetes, hypertension, and respiratory disorders were likely to predict infection, something we couldn't do in our earlier study simply because we didn't have prospective data on comorbidities on everybody, regardless of whether they were infected or not. We can also see that mortality is higher in people with comorbid status compared to without across all age groups, but this gap is greater in the 80 plus age group. So not so much in the younger age groups, but significant here. We also have it broken down by diabetes and circulatory disorders and so forth. So you can see in every particular category, you do have a differential mortality if people who are comorbid and with circulatory disorders and chronic disease, respiratory disorders, endocrine disorders, and cancers as well. So So just to say that comorbid status is actually a really important predictor also of the cases. So you can see that, so you can see the mortality here, by age group of all cases, male and female cases, again, by overall comorbid status. Now, if you look at case fatality risk, you can see that this is the number if the Madurai cases were reweighted by the distribution, the age distribution of the United States. People often think that India has had a low case fatality ratio, but that's largely explained by the fact that India has a population which is pretty young. 65% of India's population is below the age of 35, and only about 6.5% is over the age of 65. So mostly young population. So you'd have pretty high mortality rates in the Madurai cases if we reweighted by the population distribution of the US or England or Italy or anywhere else. And it's really important to keep in mind that what we really see is the burden of comorbidities really having driven up case fatality ratio significantly in India. And lastly, the lockdown was an unpopular decision when it was put in place in 24th March of 2020. But the reproductive rate definitely gets knocked down because of the lockdown, regardless of phase and of the unlocking. And we see that in Tamil Nadu and Andhra Pradesh. If we had sustained these levels of reproductive number between 2 and 4, over the course of that first 3 or 4 months, the results would have been absolutely devastating. So main messages are really to do with secondary attack rates. Our study was the largest one to show that children and young adults have an important role in transmission. They themselves don't suffer significantly from the disease, but they do play an important role in transmission. Super spreading events are the rule rather than the exception. That's concentrated in this 40 to 64 age group. And one other thing we found was that the time to death in India is pretty short. So time to death is about 5 days following admission, in fact, faster for men than for women. And this is in the first wave. The second wave, it's even faster than that. And substantial reductions in the reproductive number associated with the lockdown. And finally, comorbidities predict infection, which again has not been shown in a large study, and then also progress to mortality. So there's still many unknowns, is whether the experience of South India is generalizable to other parts of the country or other parts of the world. Why mortality rates vary so much across the country. We still have work going on to figure this out, secondary attack rates, and what determines those infection fatality rates, and then also on interventions. In fact, we had one paper on non-pharmaceutical interventions and transmission. I didn't have time to present that here, but we have other work going on here as well. So, thousands of public health workers in Tamil Nadu and Andhra Pradesh that made this work possible. Thank you, and happy to take questions.
Thank you very much, Professor Lakshminarayan. I think we'll hold the questions to the end, if that's okay. But please do type your questions in the chat box. There's certainly plenty of food for thought, and I have a number of questions myself. So thank you very much for the presentation. So we'll move directly on to our second speaker, Professor Jha, who's the Director of the Centre for Global Health Research and also Professor of Global Health at the Dalai Lama School of Public Health in the University of Toronto in Canada. He's a lead investigator on the Indian million death study, which documents the causes of premature mortality in over 3 million homes in India from 1997 to 2014. And Professor Jha is going to give us a presentation on the mortality that is attributable to COVID-19 in India. So thank you very much, Professor Jha, if you were happy to share your screen and your slides.
Good morning, and thank you very much. I'm very happy to be on the panel with my good friend Ramanan, and I've been following very much the good work that you've been doing, Ramanan. So I'm glad to see it up front and in person. What I'd like to do is...
Sorry, Professor Jha, we're just seeing all your slides. Are you able to put it on presentation mode?
Can you see it now?
We can see about 15 slides across the page.
Let me try.
So, yeah, try that. Great, that's perfect. Thank you very much.
Okay. Great. Let me just get rid of this screen. Good. What I'd like to do is to give you an overview of the studies that we've been doing describing the first wave, which mostly focuses on data from cities and looks at particularly the transmission that we think is occurring and the levels of infection. And then what we've been doing on the second viral wave, which focuses on mortality, and then give you an overview of a paper currently under review about overall excess deaths as a surrogate of COVID mortality estimates. So here's my conclusions as follows, which are that in the first viral wave, based on indirect data, we think there was quite high prevalence of infection in cities that peaked in December, with also widespread household transmission and high asymptomatic proportions, but with low death rates. That's at least in the cities in the first wave. In the second, it appears that as we now look back, only partial protection was granted from the first viral wave, and the excess death proportions from COVID at least doubled that of the first wave. And then if you look at both viral waves combined, our estimate is in the range of 2.7 to 3.3 million excess deaths, mostly this year. So something like 6 to 8 times the official death rates. Now, this is India's low death rates from COVID have been a bit of a mystery from the start. So in blue are the cumulative death rates till December 2020, and in orange are the cumulative death rates till 2021. And India has always been much lower than other comparable countries or large countries, including Latin America. And this was a bit of a puzzle. And I think this, once you look at the data more carefully and get some estimates of excess mortality, the mortality rates per population are actually more comparable than you would think. The other very simple understanding to have is that we certainly can expect SARS-CoV-2 to be in viral waves, just as influenza had hit the UK. So you see the influenza peaks in 1918-19 were in 3 waves in the UK. This was very much when the soldiers returned back from World War I. But one thing to note that even in the first viral wave, the mortality rate from influenza was vastly greater than what has been described for COVID. So even in the peak US death rates in September of last year, there were less than a tenth of those described for pandemic flu. What has been remarkable is the variation in deaths per million over time across countries for reasons that we still don't understand. So right down at the bottom is Germany, which started off with saying very proudly that they've been able to keep death rates low, higher than Canada, for example. But you see over time, the German death rates increased to above Canada. And then we have wide variation even in within European countries for, again, reasons that are not all clear. So the first part of the study that I'd like to focus on is what's happening with urban populations. So this relied on a seroprevalence study around 500,000 self-referred patients at 2,200 nationally represented or national labs with central testing with SARS-CoV-2 antibodies with 2 reasonably good assays. So this is not nationally representative. It is people who have money to be able to get testing done. The test cost about $10, $6 to $10, and it covers all of the data that we completed. And what we're looking at is the seropositivity compared to the mortality-derived infection rates using the citywide data on mortality. So here's some of the key findings. The overall prevalence showed a M-shaped pattern where it rose, peaked in younger adolescents, fell by about 20 to 24, which is the time period that houses, or that people are likely to be out of the house, and then rose over time, and then rose over age, and then fell later. So an M-shaped pattern that's very much consistent with intergenerational transfer, like Ramanan has described. The incidence, which are the new cases, had peaked in this first viral wave in December and was starting to come down. And other sero studies have noted that most of the infections are asymptomatic. So this is very consistent with widespread household transmission. When you look at the sero studies over time, you see that the fastest rate of growth was in the younger adult and the younger population, again, consistent with them being the drivers of new infections. And then for the first viral wave, at least, there was a consistent peak of seropositivity and of deaths and of cases around September, and then some declines. But of course, we know that this national picture very much masked real heterogeneity across parts of India. So when we look in contrasting, let's say Delhi, Pune, Chennai, there's the black line shows the variation in deaths, and you see Delhi actually had 2 waves of deaths, one in June and another one in December, and the cumulative seropositivity was going up. The cases, which very much depend on testing, showed the biggest increase in November. In Pune, they had a single peak, and that occurred around August to September. In Chennai, interestingly, they had a single peak of mortality, which was around July. So even within India, there's considerable heterogeneity in the patterns and evidence of repeat viral waves, which is often not remembered when, particularly the decisions to try to close down or say that the pandemic was declared over. When we make estimates of seroprevalence based on, or prevalence based on mortality, we get a broadly consistent picture with the limited serosurveys, suggesting that the high mortality rates in places that have reasonably good documentation of deaths also reflects widespread infection. But was this infection enough to stop the second wave? No. And what we've observed, I'll just skip this in the interest of time, is a big excess of deaths. Now, to understand deaths in India, you also have to understand death reporting. So there's 10 million deaths a year that occur in India. Only 7 million of them are registered for the act of death. But there's large gaps in just even basic registration. So 30% are uncounted, 3 million are uncounted. But among women, it's even larger. It's close to 60%. And then medical certification, which is a proper death certificate, is missing in about close to 90% of all the deaths. Only about 1 million deaths undergo the medically certified cause of death in certification in India. And that varies very much by state. So Bihar, UP, the most populous states, have very large gaps in the blue, which is on civil registration, whereas a place like Kerala or Punjab would have very few missing civil registration deaths, but still has gaps in medical certification. So our report on excess mortality looked at 3 sources of data: death registration, but adjusted for the actual coverage, health facility deaths from the government's own data, and then a national polling data. And let me just walk you through these very quickly. So these are the results, the summary values, the median values for the states in wave 1 and in wave 2, which is shown here. And the excess deaths grew from about 20% to 45%. In cities where we know the epidemic was more concentrated, it grew from about 40% to 85%. And in all cases, the ratio of deaths to confirmed cases was quite large, again, consistent with large amounts of underreporting. In the places where we could study deaths for 10 or more months and took into account the U-shaped pattern, meaning that deaths very much inverted U. Deaths very much quickly rose, come back down. And in the intervening months, there are very few COVID deaths, only when the pandemic waves hit again. So the proper accounting is to talk about deaths over a prolonged time period. And during the two waves, how much did COVID contribute? So these are the estimates. The key thing to focus on is the medians for the states, which is 32% and slightly larger in the cities. So this takes into account the months intervening the two viral waves where COVID deaths were not occurring. And still it shows a substantial excess, 32 to 37% approximately. The next source of data is the government's own health management information system. So this covers about 200,000, mostly public facilities, hospitals, dispensaries, all over the country. And here there's a clear excess of deaths, at least reported in 2021, that's shown in the blue, versus in the dotted line, which is the average of 2018-19. And in 2020, shown in the orange, you see there is a smaller excess, again, focused around September. By state, there's big heterogeneity. Gujarat, for example, has a 250% excess, and Kerala is only a 37% excess in the second viral wave. The last source of data, and I think interestingly the most reliable, is a nationally representative opinion poll that asked for household experiences with COVID symptoms or cases or deaths. And this COVID tracker poll reported, shown in the red, what percentage of houses reported a COVID death. And it showed a peak in September, but generally was flat. But then see what happens in April, a huge increase. Now we compare that against the baseline expected deaths, which is shown in the dotted line, based upon the Million Death Study and the UN data. So this is the basically the daily variation in deaths expected. And the whole area above, from basically April to June, the overall percentages, if you look at the excess, the percentage of houses was around 3.5%. The 3.2% of Indian houses should expect a death from all causes. And you see prior to the pandemic, deaths from all causes did exceed deaths from COVID, except in this recent period. So this recent period basically meant that there were as many COVID deaths as overall deaths in that short time period. And from these, we can make some estimates of how many deaths occur from both data, the facility data. So the estimate here is 14% in the first viral wave, excess deaths going up to 120%. But the overall time period, including the intervening months without the pandemic, was 27%. Using the survey-based data and the same approach, we come up with between 29 and 32%. When you apply these to the national deaths, which is 10.7 million deaths in the reference period, and simply multiply that by these numbers, you end up with the excess death numbers that we have here, which is between 3.1 to 3.4 million, 3.4 million deaths. If you use facility deaths, although they're not representative nationally, they are broadly geographically representative, you end up with something like 2.7 million deaths. So what are the implications? So first, the Indian COVID death rates are 6 to 8 times the official rates, and that would put them in the same range as broadly some of the Latin American countries. Our conclusions, although using different methods and different data, are similar to what Anup Malani and Arvind Subramaniam have recently published or put out in preprints. It does suggest, based on these data plus earlier evidence, there's high infection rates, but still need to vaccinate most because the infections are not providing good enough protection. Vaccination needs to be providing that protection. There is operational research needed to track vaccine response, which is going to be a practical strategy, including a lower or single dose option to pursue. Mortality and case data are needed to identify the hotspots. And finally, the most important implication is that these are indirect estimates. The Indian sample registration system does, in theory, collect annual mortality data from 8,000 distributed units all over the country, but that has not produced any evidence since 2018. And we very much urge the Indian government to re-implement this survey and to provide direct information, which would either confirm or dispute or refute our estimates or in terms of excess mortality. But this pattern that I've showed you of a peak is not unfamiliar outside of India. So in Peru, for example, you see that total deaths vastly exceeded the baseline numbers of deaths for a limited time period, and that was broadly consistent with where cases occurred. Now, finally, I think we have to think about COVID deaths in context, and the important one is to think about them in avoidable mortality. Worldwide, COVID has killed about 50,000 people a week, mostly above 70 years. But we have to note that background rates of vascular disease, cancer, even smoking account for at least 80 to 100,000 deaths a week. So we should be focusing on premature mortality and documentation. When we talk about COVID, we should be thinking about what data systems are needed to address both the routine as well as the dramatic. So to give you my conclusions again, the first viral wave appeared to be characterized by high seroprevalence in the cities with wide hotspot transmission. And the second viral wave didn't seem to have substantial protection from the first, and hence a doubling of the proportions of COVID deaths. And we estimate broadly 2.7 to 3.3 or 3.4 million excess deaths. So a substantial number greater than the official death rates. And let me thank all the GCAM investigators that have contributed. And this information, once published, will be available freely on our website, which is cghr.org/COVID. Thank you.
Thank you very much, Professor Jha. That was really fascinating in terms of the sources of data that you can use to improve our estimates. So I'll introduce our last speaker now. So Professor George Milne, who's a mathematical modeler with a research focus on infectious diseases. And George is a professor at UWA. He's led the development of highly detailed community-based models for pandemic and seasonal influenza, dengue virus, and COVID-19. And he's been using these models to evaluate some of the interventions that we put in place to manage COVID-19. So I'll hand over to you now, George, to tell us about your work.
Thank you, Jane.
Just to start us off, I'll start with a question to Professor Laxminarayan. You know, amazing data that you used, and I was wondering what's made such large studies possible in India, and what can we learn for future pandemics? What implications are there for access to good data for future pandemics?
So first of all, large data sets are going to be important, especially granular level data. And as I mentioned, India is fortunate to have, at least in the southern states and some other states, very good contact tracing, and therefore we were able to look at determinants of transmission and infection amongst contacts in a way that would have been difficult. For instance, we have similar studies running in the United States, and some of the states we work with, whether Maryland or Florida, they've had a lot of difficulty hiring contact tracers. So that's a major strength of the system. The second, of course, is the population allows for very large sizes of people to be tracked. And of course, the fact that COVID has ripped through the country is terrible from a public health perspective, but allows us to see the disease, as it moves through a very large population. Now, I think there's a lot that still could have been done and should be done. India has enormous repositories of data that have not yet been made available to researchers, and those would help us understand disease transmission, given that, we're now stuck with COVID for the indefinite future. It isn't going anywhere, and I think all countries will have to figure out how to deal with COVID, not just for next year, but 5, 10, 15 years from now, understand how, vaccines, alter the course of the epidemic. It isn't that we get to the 80% and then we're done with COVID. This is going to be a respiratory virus that's going to be with us indefinitely. And the more data we can bring to understand transmission, the better we'll be able to craft policies to be able to control transmission through a combination of vaccines and other targeted strategies that don't need lockdowns or very harsh measures which inconvenience everybody, but we might be able to target our interventions much better. And I think that at the end of the day is what we can all hope to learn from very large data sets.
Thank you very much. We have a couple of questions now. A question to George for Manu. For hard lockdowns in combination with vaccine and vaccine boosted scenarios, how long would stage 3 and stage 4 lockdowns need to be?
Yes, if you can recall some of the latter slides I showed, you can see that the outbreak can tail off really rapidly if you are about 80% of vaccine coverage. So of the order of 3 months, 3 to 4 months would be the most optimistic. And that's why I think being able to use a weaker form of lockdown rather than the hard lockdown, because that will have less impact on the economy, on children's education, on society in general. So you can tolerate that perhaps for longer. And I think that's probably the best we can come up with for managing Australia's situation. And remember, we're sort of unusual here. We have no naturally infection-induced immunity. Australia has had a number of biggish outbreaks, but not generally across the nation.
Okay, thank you. And Professor Jha, there are a couple of questions here for you. Why has Tamil Nadu experienced more COVID deaths compared with, sorry, I'll just have to move the screen up a bit, Andhra Pradesh? And what could be the possible reason behind India's low death rate? Is it because of low testing that's reduced the denominator?
I'll defer the first question to my colleague Ramanan. On the second, I think you have to look at the experiences in the first and second viral wave separately. So in the first viral wave, as in our data, the national data, but also what we had done earlier in the cities, and we focused on 12 cities with reasonably good coverage of death registration to try to look at basically the relationship between infections, deaths, and then work backwards to get a seroprevalence based upon the mortality. So working backwards. What that suggests is in the first viral wave in these 12 cities, which includes Mumbai and others, it was really not possible for there to be so many more deaths than actually had been recorded. That would mean the numbers of people infected would be close to 100%, which we don't think is the reality. So I do think in the first viral wave, there certainly was a low level of mortality. Now, what's behind that? We can speculate that it appears to be the first wave was very much characterized by asymptomatic low levels of infection, and meaning low levels of viral load that didn't necessarily contribute to really kind of quickly sick people that would require hospitalization. That was a very different scenario, however, in the second viral wave, where we see a clear excess. In the second viral wave, actually, India looks a lot like Latin American or other countries, both in terms of the trajectory of the excess mortality and then the overall mortality rates are much more comparable. So what's the explanation between the first and second? Well, we don't have enough and sufficient, for example, genotyping data to know which role variants came in or played in. We do know that certainly not just the Delta, but the Alpha and other variants were important in different parts of India. And in the second viral wave, we would have thought you'd get some partial protection against from the first wave, but it didn't occur. And so it might just well be that the first viral wave was not sufficient to provide any kind of real immunity. Think of it as a very poor vaccine that would have some impact, but not very much. And the second one had substantially higher mortality. So we really have to look at these two waves separately, because I think there's at least two different parameters going on to explain them. And then finally, it'll be heterogeneous across the country. What occurred in Tamil Nadu will be very different than what has occurred in Bihar, for example. And so for those, we need a lot better data, a lot more complete data, which, as Ramanan mentioned, is not currently available.
Thank you for that. So, Ramanan, would you like to respond? There are a couple of questions to why Tamil Nadu experiences more COVID cases compared with Andhra Pradesh, and what is the data source used in your study to analyse daily cases?
So the data source is we had the complete data set of everybody tested in the two states in which we're working, Andhra Pradesh and Tamil Nadu, which means literally every single test is in our data set. We know who was tested where, what their result was, what their progression was to severe disease, hospitalization, and so forth. So, and then for the Madurai data set, it was an interesting study because in Madurai, the authorities had a very proactive approach to studying COVID, or not studying, handling COVID. They basically would go to every single home and pull out anyone with a history of travel, symptoms, proximity to someone with COVID or any other risk factors, and check them for comorbidities and then send them for a test. So it wasn't like people had to present for tests, they were actively pulled out for tests at fever clinics, which is why we had prospective data on testing and were able to identify the effect of comorbidities on the risk of infection. We didn't have that for the larger data set, but here we had that very detailed data. Now, Andhra Pradesh and Tamil Nadu actually ended up with fairly similar levels of infections. As I mentioned, the initial phase, COVID in India was largely driven by proximity to international airports. And Andhra Pradesh doesn't have an international airport, Tamil Nadu does. So Tamil Nadu, Maharashtra, Punjab to some extent, and Delhi were the epicenters for that reason. But over time, the other places also caught up.
Thank you. George, an interesting question here. Some governments are trying to hide pandemic data, leading to faulty analyses. What can be done? Maybe that's a question to all panelists.
Yeah, well, we generate data. We don't really use data, unlike the two other speakers. So I can't really answer that. But yes, one can believe in conspiracy theories here with governments, perhaps.
Yeah, okay. And unless any of the other two panelists have anything to say, I'll move on.
I think governments don't really hide data. They're just politicians and bureaucrats are scared of releasing data. They think that it's better the public not to know, or it's going to embarrass us. But there is simply no way to walk out of a complex pandemic without a lot more data being publicly available. That is part of building the confidence that's needed by the public to know that things are improving. And in the case of mortality data, I think disaggregated mortality data being released would also point out where are the hotspots of transmission, because deaths represent ongoing community transmission. And so identifying those is not just central for accounting of the deaths, but actually can help shape the vaccination strategies by knowing which are the hotspots, which are the areas that do need attention. I think the Indian government somewhat understands that, but there's not enough voices saying that it absolutely needs to rely on data to move forward, not think that data will somehow harm the response.
So just, sorry if I can take the chair's prerogative. I was wondering, you mentioned you did the comparison of deaths related to, say, cardiovascular disease and cancer and COVID deaths. I was just wondering to what impact has COVID-19 had on other causes of death through people not being able to or not accessing healthcare that they might normally receive for some of those conditions?
We don't have good enough evidence on that. The HMIS data suggests some increase in, for example, maternal deaths, but those appear to be mostly COVID cases in pregnant women and not a collapse of, let's say, delivery services. We know from other settings, however, for example, from Ebola in Sierra Leone and in Liberia, that while Ebola killed about 10,000 people during that entire pandemic in that region, the numbers of deaths from neglected conditions of childhood, particularly malaria treatment, were probably even greater. Now, those data we don't yet have from India as to what are the other effects, but it would mostly be on the things that are very sensitive to the health system, not necessarily the more routine conditions, which pushing off a cancer diagnosis for 2-3 months may not necessarily lead to an excess mortality, but pushing off malaria treatment certainly would. So we don't know that.
Yeah, okay, thank you. There's a comment here from Usharan. Data and especially access to data has always been a major barrier in India for most health-related work. COVID pandemic is no exception to this. The authorities have failed miserably in many parts to track the infected persons, even in a small population of international migrants who disappear once they've landed in their place of destination by giving false contact details. This is, these are the challenges on the ground, aren't they, in terms of field work in infectious diseases?
Oh, sure, and even the percentage we estimate, or the various serosurveys of asymptomatic, might be overestimated simply because you don't want to report symptoms on a survey out of fear of quarantine.
Yeah.
So all of these things have to be considered and looked at carefully.
Yeah. So we probably just have time for 1 or 2 more questions. So I think I'll just keep going down the list. It's probably the easiest one. So thank you, George. When could we stop lockdowns using your model? Are we stuck with stage 3 lockdowns from this point forward? Should we not be changing our modelling to be monitoring deaths rather than infection numbers when we have effective protection from vaccine?
Well, yes, I think that's right. And there's another comment there from Ankit about in the UK with less restrictions in place. Going back to front, in the UK, time will tell whether their opening up has an impact on transmission and, say, deaths. In terms of, it's fairly well understood that vaccination does protect you against illness and death. So I suppose the answer is yes. Once we can get 70–80% of the population vaccinated, we might still get outbreaks superimposed on that. But the risk to individuals who've been vaccinated will hopefully be significantly less. So the health burden effects then will be reduced as well. That would be what we might hope for.
maybe on a point of what we might hope for, and given people's other obligations for the day, I think we'll call the session to an end now. There may be opportunities for us to download the chat and possibly forward those questions on to the speakers for response at a later time. But I would like to thank all the speakers for their clarity and the extent of information that they've given us, and for ensuring that we think not just about the impact of COVID-19 on case numbers and death, but also the social and economic impacts, and thinking about how we might in the future improve data. So thank you to all the three speakers. Thank you to the audience for your participation and great questions. And I'm sorry that we have run over time, but thank you all once again, and enjoy your day or evening, as the case may be. Okay, thank you.
Thank you.
Bye. Thanks, Jane.
Okay, good night.